Well, hello everybody, and I welcome you all, and thank you so much for taking your time. I'm an endocrinologist, I'm not a surgeon, but I see patients with Dr. Stang in the clinic, and my main area of interest is thyroid nodule and thyroid cancer. I'm going to talk about thyroid nodule tonight. A lot of time when I see patients in my clinic, they are being referred with diagnosis of thyroid nodule, but they are not exactly sure what thyroid nodule means. And that's why my first slide is going to try to explain exactly what the nodule means. Thyroid nodules is an abnormal growth of the thyroid cells. And thyroid gland, it looks like a butterfly. Okay. It's in the lower part of the neck, and it technically makes thyroid hormone for us, which we need that for our metabolism. Sometimes you can have a growth in the thyroid gland, and that's what we call a thyroid nodule. They are very common. It's not something rare. And usually they are discovered incidentally. It's not uncommon for us to see patients in our clinic that they were seen in the emergency room or they were seen by their primary care. They had a CT neck or CT chest done for different reason, and they're found to have thyroid nodule. Or in the MRI. Fortunately, most of them are benign. Over 90% of these thyroid nodules are benign. But sometimes they are not found incidentally. Sometimes you feel the lump in your neck, or your primary care, when they're examining your neck, they feel the lump. That is why it's very important that when you see your primary care physician, you always ask them to examine your neck, because that should be part of the regular physical exam. You may not notice the lump, but your primary care, they should be able, not all the thyroid nodules are palpable during the physical exam, but some of them are. And that is why it's important that you always ask your primary care to check your neck as part of the regular physical exam. Even though more than 90% of the nodules are benign, but some of them, they can be cancer. And that is why if you have a nodule, we need to know about it. It's important that if a nodule is found in the physical exam, further evaluation needs to be done, for sure. So a lot of time when I see patients in my clinic, they come to me and they have a nodule, and they always ask me, then why don't I have any symptoms? Because most of the nodules are small, or the nodule needs to be really big to cause symptoms for you. If they're big enough, they can cause difficulty swallowing or difficulty breathing, but a lot of times you may not have any symptoms. I get that questions all the time from my patients, and how come I have a normal blood test? My doctor checked my blood test and my thyroid function is normal. It doesn't matter. You can have a nodule and you can have absolutely normal function, because thyroid nodule is a growth in your thyroid gland, and it doesn't necessarily affect the function of your thyroid. That is, by having a normal blood test, it doesn't mean you don't have thyroid cancer. Now, what do we do? If you find a nodule incidentally in the CAT scan or MRI, or if your doctor finds a nodule, or you feel a lump in your neck, what is the next step? The best test to evaluate a thyroid nodule is an ultrasound. Sometimes, we need to actually biopsy the nodule. We don't biopsy every single nodule that we find in the ultrasound. We make that decision based on the size of a nodule and also how the nodule looks like in the ultrasound. But that is important that you start by getting a thyroid ultrasound, and then you should see a specialist after you get your ultrasound done, and the specialist can make that decision if you need to have a biopsy done or not. Thyroid ultrasound doesn't have any radiation. It's not like a CAT scan or MRI. It's technically a probe that the radiology tech, or sometimes the endocrinologist, they do it in the office. They will just scan your neck, and they can take pictures of your thyroid gland. It uses high-frequency sound waves to uptake pictures of a thyroid gland. And it can help us by looking at the thyroid ultrasound. We can tell you how suspicious your nodule is. And we can actually tell you what is the risk of malignancy in that nodule. The other imaging studies like CT scan or MRI are not very helpful to evaluate thyroid nodule. But the ultrasound can help us, and we can definitely tell you the risk of malignancy when we look at your ultrasound imaging. This is an example of what we see when we look at your ultrasound imaging. This is your airway, and this is your thyroid gland, which looks like a butterfly. It is around your airway. And if you have a nodule, and technically you will have your carotid outside of the thyroid, and the rest of it are muscle. If you have a nodule, it looks different. It looks like a growth inside the thyroid gland. And that's what we see when we look at your ultrasound. Nodules, they can look different when we look at your ultrasound. And sometimes they look dark. Sometimes they have white spot inside them. And that is how we can categorize nodule to low suspicious or intermediate suspicious or high suspicious. What if we decide to biopsy your nodule? A lot of times patients get really, really scared just thinking of us putting a needle in their neck. Well, in the past, when the ultrasound didn't exist, people used to do a blinded biopsy. They used just to try to palpate the nodule and put the needle in, and insert the needle in the patient's neck. Now we use the ultrasound machine to guide the needle. Then we know exactly where we are going and we know what you're doing. And that is how it looks like. We can see the needle under the ultrasound machine, and this way we can be sure that the sample is obtained from your thyroid nodule. And even though it might sound really scary, it's really a minor procedure. It is done in the office, and there is really no major side effects. I mean, there is a very, very small risk of bleeding. There is a very small risk of infection. And it's to the point that you don't even need to have general anesthesia. We would just use topical medication to numb the skin, and we do the biopsy. And a lot of the patients they can go back to work after the biopsy because it's a really minor procedure. It's not that painful. And that's how we do. We use a very small needle. It's much smaller than the one that is used for blood draw to get the cell from your thyroid nodule. And we usually try to get at least 3 to 4 samples. I mean, sometimes we might be able to get enough sample just with 2 passes. And then we get the sample and we give it to the pathologist. Then pathologists will look at those samples under the microscope, and they will give us answer. If you see me or Dr. Stang in the clinic, we'll tell you in the first visit that you might get 4 different answers from us. If we call you and tell you your nodule is benign, it means you do not have cancer, and we're good. But still, we follow the thyroid nodules, which are benign. Sometimes it might come back cancer. If it comes back cancer or it is suspicious for cancer, then we send you for surgery. But this is not always the case. Sometimes there might not be enough cells in the sample, and that is what the pathologist may not be able to give us an answer. And that is why we call it non-diagnostic. In that situation, your doctor will decide if the nodule is low suspicious and they are not too concerned about it, they can just continue to monitor that. But if they're concerned about the nodule, they might repeat the biopsy or send you for surgery. Sometimes it's in this category. Your doctor may call you and tell you, well, it is not benign, it is not cancer either, but it's something in between. It means the pathologist is seeing enough cells. I mean, technically the sample is diagnostic, but the cells, they don't look completely benign. They don't look cancer either, and that's what we call it indeterminate. In that situation, the risk of malignancy depends on what type of indeterminate is. It could be between, around 15 to 30%. And in that situation, we have a new tool that is available in most of the academic centers and some of the private clinics, and that's the molecular testing. If this is the case, your doctor may talk to you about this test. The way that it works, technically, they will bring you back, or sometimes they get the sample with the first biopsy, and they will do a repeat biopsy. And they will get the sample, and they will send the sample to the company that actually runs the molecular testing. And they will check for different type of the mutations. And that test would help them to decide if they can watch the nodule or they should send you for surgery. There is a test that a lot of times I get that questions from the patient, and that's a nuclear thyroid scan. That's a test that actually, they give you really low dose iodine, and then they take pictures of your thyroid gland 24 hours after. It used to be used a lot in the past when the ultrasound was not available, and the physicians, they used to use this test to decide if they should technically follow the nodule or they should just take it out. We don't use it anymore that much. The only time that your doctor might order that test is when you see your doctors in the clinic and they find that you have a nodule. At the same time, the function of your thyroid is not normal. If the function shows that your nodule is overactive, if the function shows that your thyroid gland is overactive, in that situation, your doctor will order that test for you. Because sometimes you can have a nodule which is overactive, and that can be the cause of your overactive abnormal thyroid function. That will be the only time that we may actually use this test. But we don't use it in every single thyroid nodule. And it used to be used, but not anymore. Since we have the ultrasound, we have better tools to evaluate the thyroid nodule.
So I'm going to be talking about hyperparathyroidism. That's a mouthful. Hyperparathyroidism. Most of the time, I get a question, what is a parathyroid gland? And that's what I hope to convey this evening. And we just talked about the thyroid, so we're in the same ballpark as the thyroid. We're in the same zip code, but tucked up back behind the thyroid are these 4 tiny little glands called parathyroids. They do something completely different, similar name, but totally different function. And if you imagine that this is now pulled off the windpipe or the trachea, and you can see the thyroid from the back side, that's where these little guys live. Most of us are born with 4 of them. They all do the same thing. They're very tiny, but very important. They're tucked away behind the thyroid. Each is only about 30 milligrams and about 4 to 5 millimeters across. And for me, seeing these in the operating room, they look like tiny little lentil beans, kind of stuck to the backside of the thyroid. So the next question is, what do they do? Because that gets to why hyperparathyroidism is something that needs to be treated. So parathyroid glands are constantly, and they're doing this minute to minute. You never have to think about it. They've been doing it your whole life. And they're constantly measuring the amount of calcium in your blood, and then they respond to that. And the main way they respond to this is by making a hormone called parathyroid hormone. We refer to it PTH. It's a lot simpler to say than parathyroid all the time. And that hormone helps you regulate your calcium level. So in general, PTH or parathyroid hormone raises the level of calcium in your blood, and it does this mainly by breaking down the calcium crystals in your bone. So it helps dissolve the calcium out of your bones so it gets into your blood, and that helps bring your blood calcium up to a normal level. The other thing it does is it makes vitamin D, which we all get in our diet, it turns it into the more active form of vitamin D, and that helps you absorb more calcium from your intestines. Lastly, it also affects the kidneys. Sometimes the kidneys they'll hold on to calcium a little bit more, and that can sometimes help raise your calcium level. So in general, as the parathyroid hormone level increases, all these things increase to help raise your blood calcium. Conversely, if your blood calcium is a little bit too high, the hormone level will come down, and all these processes will reverse themselves. The calcium goes back into the bones, the intestines don't absorb as much, and the kidneys won't be so uptight and can release some in your urine. Again, if your parathyroid glands tucked up back here behind your thyroid, if they sense a low blood calcium level, they'll increase this hormone PTH. It affects the bones, kidneys, and intestines, all of which are meant to increase the blood level. And then as your blood level increases, there's just a very natural talking back then to the parathyroids to stop this whole process. And essentially, it just keeps a very nice balance. So when your blood calcium is too low, the PTH is released, and that brings the calcium back up to normal. And then when the calcium level is normal or actually gets a little bit too high, that PTH decreases, and it's a very delicate balance, because proper calcium balance or a very normal range of calcium in your body is crucial to the functioning of your heart, your nervous system, and your kidneys, as well as your bone density. What is hyperparathyroidism? Well, hyper, agitated, overactive. It's when these little glands start doing a little bit more than they should. So hyperparathyroidism is a disease in which one or more of these little parathyroid glands, these little guys, grow and become overactive, and then they start just constantly making too much PTH. This leads to calcium being taken out of the bones and increases the calcium absorption in your intestine, and abnormally raises your blood calcium, for the most part, to be too high. But in general, one of these little parathyroid glands enlarges, and as it does, it just starts dumping out all this PTH and forces your blood calcium to go up higher than it really should. It pushes your whole body out of balance. So when we have these enlarged parathyroid glands or hyperparathyroidism, 80 to 85% of patients actually just have one gland that's abnormal. So it's just one of these little four that are causing this whole problem. About 15 to 20% of patients, it's either a double adenoma, which is two, or sometimes it's three, or even all four glands that are big and overfunctioning. In general, and this is one of the common questions I get from patients, is this cancerous? And 99+% of the time, it's not. This is a benign growth. This is something that actually happens quite frequently. Parathyroid cancer can happen, but again, it's much less than 1% of all cases of patients who have hyperparathyroidism. Who's affected by hyperparathyroidism? It's actually a little bit more common than we think. You don't hear necessarily a whole lot about it. It does become more common as we get older. Certainly as we reach our 40s and go into our 50s and 60s, it becomes more prevalent. The average age at diagnosis is 65 in the United States. All told, about 1 out of 100 people will be diagnosed in their lifetime. However, women are 2 to 3 times more likely to be diagnosed, which means for women, especially women who are after menopause, it's actually about 1 in 50 women will be diagnosed with elevated calcium caused by hyperparathyroidism. In general, if you get that blood work or copies of those blood work and you see a high calcium level, for the general population, the vast majority of the time, it's because of this problem. We are not designed to have a high blood calcium, and those levels are really never normal. And so for somebody to have a high blood calcium and said that, well, that's just you, or that's just where your body wants to be, that's not true. It's usually because there isn't an appropriate hormone balance with respect to these parathyroid glands. There are other risk factors that can cause hyperparathyroidism. One is for patients that take lithium. It can really affect these glands, in large part because lithium is very much like calcium, and so it tends to screw things up a little bit. For those patients that have had radiation treatments to their chest, neck, or head, predominantly those younger patients who have had Hodgkin's lymphoma and were treated with radiation maybe when they were teenagers or in their 20s. And then for women who are 20 to 30 years out from breast cancer treatment and had significant radiation to their chest, are at an increased risk of developing enlargement of these parathyroid glands. There's also a family connection. There are certain families where this sort of disease or this problem with the parathyroid glands can run in families. The next question, or the most common question I get from patients, is why is this bad? If my calcium level is high, that means I'm doing a really good job of drinking my milk. That's not true. It's important to be treated. And again, this comes back to just understanding the natural balance that our body wants to be in and how it reacts to the hormone being out of balance. This artificially elevated blood calcium is at the expense of stealing it from your bones. Again, this is most common in postmenopausal women, a population of patients that were already concerned for osteoporosis. And now this on top of it will only accelerate that bone density loss and increase the risk of fracture in your lifetime. Every cell and organ in the body uses calcium. It's an incredibly important element in our body. Our nervous system uses it to conduct electricity. All of our muscles use it to actually work that contraction of the muscles. And when the calcium level is off, all of those things are dramatically affected. Along those same lines, abnormally high blood calcium levels, meaning calcium levels where we're not designed to be at or live at, will affect and or damage almost every organ in your body over time, if left untreated. So again, coming back to the main things that are impacted is the bones. So that can, over time, decrease your bone density, leading from what would be hopefully a normal bone density to osteopenia. That's that first stage of losing bone loss. You're just kind of not completely normal. You're not quite to osteoporosis. You're somewhere in between. About 30% of patients that have high blood calcium due to hyperparathyroidism will develop kidney stones. They'll develop calcium kidney stones. Now, not all patients with kidney stones have hyperparathyroidism. A lot of kidney stones are caused by uric acid. But of those patients that do have calcium kidney stones, a fair percentage, somewhere around 10 to 15%, will be caused by or found to be caused by a problem such as this. More importantly, for those patients where this is not picked up or not treated long-term over time, that kidney is filtering the blood constantly, and that high calcium level is very stressful, and the kidney itself will become slowly calcified over years, and that leads to permanent kidney damage, if not to some extent kidney failure. Again, affecting the nervous system and the muscles of the body, it has dramatic effect on your blood pressure. It can make what would be possibly easily treated high blood pressure, make it harder to control. It can cause or accelerate hardening of the arteries, the atherosclerosis. Along with that, the coronary artery disease or the heart blood vessel disease. Because it has a worsening effect on high blood pressure, it causes enlargement or hypertrophy of the heart. And then also can affect the natural heart rhythm because it's affecting those nervous impulses. Again, so in some places in the world, this isn't necessarily treated, and it's just left. And so from those populations, we learn a lot. And we actually see in certain populations, such as Scandinavia and other places where they haven't been really aggressive at trying to treat this, hyperparathyroidism is associated with premature death. It sounds scary, but it has that kind of long-term effect on somebody if it's not fixed. More importantly, for the average patient that walks into clinic with a diagnosis of hyperparathyroidism, they just do not feel well. They haven't felt well for years, and it leads to a decreased quality of life. And the main reason they don't feel well, it's because every muscle and bone in their body hurts. Because that PTH, that high PTH is leaching or sucking the calcium out of your bones, that hurts. And they just ache constantly. Further, that high calcium level tends to slow those electrical impulses, so we just get foggy. It's like there's a brake put on, and there's just no gas left in the tank. You have problems concentrating. Short-term memory becomes more difficult. It's harder to process just normal day-to-day things. You don't have the same motivation. You're significantly fatigued. And it can really exacerbate depression, anxiety, irritability. A lot of that may be because there's dramatic effects on your sleep patterns. It can really affect normal sleep behavior, causing to some extent either insomnia or really disrupted sleep where you're not getting good sleep. Again, this is just more of a picture illustration of it affecting the whole body. The head hurts from the standpoint of being unable to think more clearly and being fatigued. All the bones hurt. A lot of people tend to get a lot of abdominal complaints. Their belly hurts. They get constipation. It affects pretty much everything. The good news is that if you fix it, 80 to 90% of patients will report that all of these things dramatically get better. And so how is it cured? So parathyroid surgery is the only known cure for this. And going back to the first slides in explaining what is it, it's enlargement of one or more of these glands and they just start making too much hormone. From a surgery standpoint, the treatment is quite easy. You find the glands that are big and not working properly, and those come out. You leave the ones that are normal and working normally, you leave those in, and the body will come back to normal balance. Again, the goal of surgery is by the time that patient leaves the operating room, we're measuring the hormone level in the operating room. The hormone level changes that quickly within minutes. You can see it go from a very high level down to a low normal level, and you know that patient has a 99% chance of being cured. Once you get that hormone level down to normal, the calcium will take care of itself. That balance will come back. Again, after successful surgery, bone density improves by as much as 8 to 12%, and the risk of fracture significantly decreases. It halts the calcification of kidneys and eliminates, for those patients that have developed kidney stones, it eliminates the formation of new kidney stones. It won't necessarily fix the ones that may have already formed, but it will prevent the formation of new ones. And again, when you look at really those patients that have all these symptoms and you give them very extensive questionnaires, 80 to 95% of patients asked the questions before surgery and 6 months after surgery notice dramatic improvement in a lot of these symptoms, especially with the bone aches and the memory fogginess and the fatigue. And along with that, then, the improved quality of life. I've included some general resources that are on the internet. Buyer or beware on the internet. I would really stick with the .orgs or .edus with respect to education materials. The .coms use at your own risk. But in general, so these are websites from the American Association of Endocrine Surgeries and the American Association of Clinical Endocrinologists, as well as the Duke Healthcare website. Again, Dr. Ahmadi and myself run a multidisciplinary team, surgery and endocrinology together in the same clinic. A lot of times we'll see patients together at the same time to help expedite the evaluation. And we're right across the street at Duke Raleigh. Our office number and scheduling number are on those sheets. And with that, we'd be happy to answer questions.